you. So I'll just, just introduce Wendy Wray. She's absolutely fantastic. We love her so much. She's doing so much for women that people have no idea. Her commitment and passion has been there her entire life. And we are so grateful to have Wendy to be able to speak with you today. So just want to give you a formal introduction, Wendy, and say thank you so much for doing this. And I leave you in the capable hands of Wendy Wray. And if you have any questions, Wendy will take them at the end of her presentation.
Tara, hope everybody can hear me. First and foremost, I want to thank you for your very generous donation to our project, the Women's Healthy Heart Initiative. I was saying a few minutes ago, we opened in 2009, and even in 2023, we're still struggling with sustainable funding. So your contribution, your donation is hugely, hugely appreciated. So thank you very much to everyone. I thought the way we would do this session today is have a conversation about women and heart disease. And the first thing I'm going to do is I'm going to introduce you to Sophie. And Sophie, and this is a true story. Sophie's a 44-year-old woman, was a 44-year-old woman. And it was a holiday weekend, a 3-day long weekend, holiday weekend, and she was hosting. So Friday, she has a house full of guests. She's preparing meals. There are kids running around, relatives everywhere, kitchens full bore, as we're all familiar with in our lives, I'm sure. We've all been in the same situation, but she wasn't feeling well. She was feeling a little sweaty, a little short of breath, a little nauseated, a vague discomfort in her chest. And she told everybody that actually she wasn't feeling great, but pushed through. The way that as women we often do, because we have things to do, and that often takes priority. So she gets through the Friday, and again, she's still not feeling well, a little short of breath, a little sweaty, a little nauseated, a little discomfort in her chest. And again, she had told people that she wasn't feeling well. So she goes to bed on the Friday night, and she gets up Saturday morning of the long weekend, and again, she's got a house full of guests. She's preparing meals, getting the table ready, et cetera, et cetera. So she goes into the kitchen to make breakfast that morning, and she drops dead. She falls to the floor and she drops dead. So I think Sophie actually represents a lot of problems when it comes to women and heart disease. And using Sophie as kind of a baseline, I want to talk about a lot of the issues that are surrounding women and heart disease. In 2023, Heart and Stroke Foundation states that women remain underaware of the risk of heart disease. They are underdiagnosed, undertreated, and under-researched. Additionally, we know from research that women also experience sex and gender disparities. As colored women, they experience same and different disparities, as well as immigrant and Indigenous women, especially from an access perspective, as well as things like language barrier and cultural norms. So when we look at that statement, it's really kind of scary that, we've known since the 1980s that women have a risk of heart disease. It's traditionally known as a man's disease, but it's a women's disease as well. So I think we start from lack of awareness, because when I think about Sophie, she's 44 years old, and I have to wonder if her doctor, if she had a GP, which is another barrier that we're all experiencing, if the GP had even talked to her about women and heart disease. So we know all this information is research-based, that those women who have gestational diabetes, because she had 2 children, she had a 9-year-old and a 12-year-old. So she had 2 children, and whether during her pregnancy, did she have gestational diabetes or blood pressure issues? We know from research that those women who have those complications during pregnancy It's not a pregnancy issue. It's actually a cardiovascular issue. And those women are more likely in as little as 10 years. So by the time that child is 10 years old, are more likely to actually develop diabetes or high blood pressure. Also, women with polycystic ovary disease syndrome, they are also at higher risk for cardiovascular disease. Premature menopause. So the average menopause for a woman is 51 years of age. So premature menopause, either surgical or natural, at let's say 40 to 44. You can imagine that those women have less natural protection that we as women have protecting us from heart disease if they had made it to the age of 51. So those women are at higher risk. There are also risk factors that are more potent in women than men. So, for instance, we don't know whether, Sophie was a smoker. Smoking in women is more potent than in men. The hypothesis is that as women with our hormone profile, we tend to pick up more of the toxins from the smoke than men do. Diabetes is more potent risk factor in women than in men. When a woman becomes diabetic, she increases her heart disease risk by 46%, whereas if a man does the same, becomes diabetic, he only increases his heart disease risk by 25%. So we're almost double the risk that men have. When it comes to going back to Sophie once again, we also know, and we don't know in her case if her children were preterm, if they were born early. Those women also tend to have an increased cardiovascular risk. So while there are lots of similarities between men and women in heart disease, there are also, as I've mentioned, a lot of differences between men and women when it comes to heart disease. So these things we need to be aware of, because from a prevention perspective, if we're not given information about our risk, then how are we supposed to do something about it? And that's a lot of the work that we do in the Women's Healthy Heart Initiative, is that we make sure that women have the information that they need, because heart disease, and there are different diseases in the heart. We're talking specifically today about atherosclerosis. And atherosclerosis is basically narrowing of the coronary arteries. It's the blood that carries the oxygen to the heart. And if those arteries narrow down, as you can imagine, there's less blood supply to the heart. It can lead to angina, heart attacks, etc. And probably what Sophie had was she had a massive heart attack, and that's what happened to her. Heart disease is 80% preventable. So when you think about that and think about other diseases, and probably cancer comes to mind, because that's another disease for women and the general public, we know very little about how to prevent cancer. It's very complex. Whereas when it comes to heart disease, atherosclerosis particularly, the fact that 80% of it is preventable, I as a woman want to make sure that I have the information I need to self-care. So to take care of myself when services aren't available or when they're not offered to me. Still on the theme of awareness, there was a survey that was done only a few years ago. They asked physicians, if you have a man and woman in your office, and they have the same heart disease risk factors, or they both had a heart attack, who would you give more information to? And just a few years ago, physicians said they would give more information to the man. Now, how can that possibly be? Because when it comes to our risk, 1 in 3 women die of heart attack or stroke. Whereas when it comes to ovarian cancer, 1 in 86 women die of ovarian cancer, and 1 in 25 of breast cancer. So you can see how common it is, And yet the physicians are saying they would automatically give more information to the man. I can pretty well assume, knowing, having heard about that survey, the results of that survey, is that women are not getting the information that they need. The other thing that concerns me is when it comes to empowering ourselves, do we know what we should be asking? Because if we go in there and we sense that maybe we're not getting the information we need, then we should be armed with the questions to get the information that we're looking for. So that's a lot of the work of the WHHI, and the reason that we do that. So I think the best thing now is we'll briefly go through the heart disease risk factors and the questions, the information that we should be asking and that we should have when it comes to empowering ourselves with self-care, because it is so largely preventable. So one of the main risk factors of heart disease in both men and women, of course, is elevated cholesterol. And we've all heard about elevated cholesterol. And I think the most important thing is to know our numbers. And a simple question is to ask your healthcare provider, is my cholesterol normal? And just knowing whether it's normal or not, then we're aware of whether we have an issue or not. Cholesterol, there's good cholesterol and bad cholesterol. The HDL, good cholesterol, we like it because it protects us. So that's why we call it the good cholesterol. The bad cholesterol is called LDL-C or ApoB. We don't like that particular cholesterol because it tends to block and narrow those coronary arteries that we talked about before, that it's through there that the blood is supplied to our heart. From a lifestyle point of view, because we know overall, given a choice, surveys have been done, given a choice between taking a medication or using lifestyle to improve our heart health, women overwhelmingly will choose lifestyle over medication. And so that's another reason in WHHI we focus on lifestyle as a treatment. From a lifestyle point of view, in elevated cholesterol, sometimes we can modify that bad cholesterol, lowering it through weight loss. It doesn't work for every woman, and not every woman has to lose weight, so it's very individually based. But as I said, sometimes weight loss can lower that bad cholesterol. Really, from a lifestyle point of view, there's not much else we can do. To a certain extent, we're genetically driven, and as you know, we can't change our genes. The next thing that's a risk factor that's very important is high blood pressure. High blood pressure is very common. I was reading something recently that 1 in 4 Canadians have high blood pressure. Most of us don't know we have high blood pressure because we usually don't have symptoms when we have high blood pressure. So unless someone is checking our blood pressure, we might not even know we have high blood pressure. Our blood pressure tends to go up as we age. Why? Because our arteries become less supple. There are 4 things in your lifestyle that can help you maintain a good blood pressure or lower your blood pressure. First of all, regular physical activity. Let's say you go for a nice brisk walk for 30 minutes, let's say, for up to 12 hours after you take that walk, it can have a blood pressure lowering effect. And this is just, you're not taking a medication, you're simply going for a walk, something we should all be doing on a daily basis, a regular physical activity. Secondly, salt. If we tend to eat out a lot, if we tend to eat a lot of processed foods or add a lot of salt to our food, we can elevate our blood pressure. Research has shown that even cutting back, you don't have to cut salt out, but even if you cut it back 5%, it can make a difference in blood pressure. Number 3, alcohol can aggravate high blood pressure. And weight loss. Number 4, weight loss can naturally lower blood pressure. It's generally 1 to 3 millimeters of mercury, so 1 to 3 points of blood pressure per 5 pounds. The next thing is diabetes. And as I said, diabetes is more potent in women than men. We do almost anything to make sure our women don't become diabetic because of that increased risk. When it comes to diabetes type 2, type 1, we don't make enough insulin, and that's about 10% of the population. But most diabetes is type 2, and it comes down to two things from a lifestyle perspective. Number one, regular physical activity. And the whole point about the regular physical activity is when you are doing that activity, you're actually burning sugar out of your system. And of course, nutrition. So nutrition is very important as well. Diabetes Canada, they have a very busy website, but they have it's a 3-page information, including a menu, which is very helpful to know from, what you are eating and what you should be eating. It's called Just the Basics, and it's on the Diabetes Canada website. So what we do is we ask the women to look at this menu that's recommended and compare it to what they're actually eating and see how they can, slowly over time get closer to the diabetes recommended diet. From a smoking perspective, no smoking is good. The jury on vaping and the dangers of vaping is still out, so zero smoking is best. As I said earlier, smoking tends to be more potent in women, and the absolutely highest risk combination is a woman who is smoking, who is also taking the oral contraceptive pill. She increases her heart disease risk by 30 times, which is kind of horrifying when you think about it. But again, how many women know that, and especially our younger women? Regular physical activity. I was reading something recently and I thought it described regular physical activity very well, in that it's probably the most powerful drug you will ever take. There are so many benefits to regular physical activity. What we're looking for and the goal should be is 150 minutes of physical activity a week. That basically works out to 30 minutes a day, 5 days a week. We're all busy, so sometimes we don't get to do it 5 days a week. We recommend that you not break it up into any less than 2 days. It should be, 3 or 4 days. And more than 150 minutes is even better. When it comes to physical activity, it takes time. And so if you can't do the 30 minutes in one shot, no problem. You can break it up. You can do 10 minutes 3 times, 15 minutes twice, 5 minutes 6 times, whatever it is that fits into your schedule. I had a patient once, and he had I was dealing with men at that time. He had no time during his day when he got home from work to exercise. So what he did 3 times a day was in his office, he went into the stairwell and he went up and down the stairs for 10 minutes. And then he would go back to the desk and work again. And he would do that 3 times a day. So he instilled his physical activity into his work day. So it didn't take time on either end of his day. And probably at the end of the day, he was tired anyway. But it just goes to show how we often think we don't have time to do these things. But depending on how we work it into our schedules, it's very possible. For women, it's also very important. We tend to work out the big muscles, so the waist down. We're doing the elliptical and we're running and we're doing the treadmill and et cetera, et cetera. We often don't work out our upper body, and it's very important to do that through muscle resistance training, weight training, et cetera. The ideal workout for a woman is actually 50% aerobic, which is your walking, running, swimming, et cetera. And the other 50% should be your weightlifting and muscle resistance. The other plus about the muscle resistance and weight training, of course, is bone density, which we're always concerned about as well. And it can help maintain and improve your bone density. From a weight point of view, obesity is something, we talk a lot about weight in our project, and the average age of our group is 58 years of age. And so many women have told me they're so sick of talking about and dealing with weight that often from teenagehood on, we're dealing with it. There's societal pressure. We have our own pressures, et cetera, et cetera. I think the goal when it comes to weight is that we should avoid obesity as much as possible. That's a body mass index of 30. Body mass index recently in the media has taken a bit of a pummeling because it doesn't differentiate body composition, which is true. So how much muscle base and how much fat composition there is. But it is a good guideline because we know in obesity, the body mass index of 30, we increase our cardiovascular, our heart disease risk. So staying below 30, we know from research that if a woman's body mass index is 29, which is perhaps heavier than she should be, but if she has a good fitness level, actually the fitness level will decrease her cardiovascular risk. So it doesn't have to be all about weight. And I think that's kind of a relief for a lot of us because there is such pressure about weight. I think the fitness level is and as shown from research, is equally as important. So those are the basic risk factors. When it comes to heart disease, there are 3 risk factors that are non-modifiable, so you do not have control over. And that's going to be if you have a family history of heart disease, but you should be aware there's often a hereditary factor. So you should be aware of that it might put you at greater risk if you do have a family history of heart disease. Whether we're male or female, although that's kind of changing, but for the moment, and how old we are. As soon as we hit 50 years old on the Framingham risk score, we get 6 points. From the day before to the day after, we automatically have 6 points because we're over 50. Everything else from a heart disease perspective, risk factor is modifiable. And those are the things that we've talked about, which is elevated cholesterol, high blood pressure, diabetes, smoking, obesity, regular physical activity. And nutrition, of course, is very important. We recommend and is highly recommended the Mediterranean diet, which I'm sure a lot of you are very familiar with. And the DASH diet, which is actually the dietary approach to systolic hypertension. It's similar to the Mediterranean diet and has actually knocked the Mediterranean diet out of the #1 spot. And the reason for that is that it's low salt, whereas the Mediterranean diet is not a low salt diet. And of course, from a heart disease point of view, less salt is better. I feel like I'm doing a lot of talking, which I am. So I think when it comes to Sophie, who was 44 years old, going back to her, I'm really concerned about symptoms. Now, we haven't talked about symptoms in heart disease, and I think I have a few minutes before we open up for questions, because of course, symptoms are very important. We are actually a prevention project. We don't have many patients who have had cardiac events because our goal is to get to women from 45 years of age because first heart attack in women, the average age is 71. So if we can catch women in their 40s and address those cardiovascular risk factors, then as you can imagine, when she gets to 71 years old, she has had years of lower cardiovascular risk because her blood pressure is under control. She's lost weight. She's exercising regularly. She's going to sail right through 71 years of age without sustaining a heart attack. So symptoms, I know there's a lot of discussion about symptoms. Symptoms for a heart attack in women can be different than men, but still the #1 symptom of a heart attack in women is chest pain. Now, chest pain, pain is a very interesting and ambiguous term because we all experience pain differently. And from my experience, I think as women, we probably experience pain differently than men do. Simply, well, for several reasons. #1, many of us have had children. and childbirth can be quite painful. We can have painful periods, and we can also have painful intercourse. So if someone said to me, Wendy, if you're having a heart attack, I want you to look for pain that's probably going to feel like burning, heaviness, tightness, pressure, or squeezing, I would think, I would be uncomfortable with that, but I'm not sure I would think of it as pain. So I think it's something we need to be aware of, because if we're waiting for a childbearing type of pain, it's most likely not going to happen. My screen's just not, oh, there you're back. It's probably not going to happen. So I think it's important that when we think about it, that it's not so much pain, it's more of a discomfort. So again, a burning, heaviness, tightness, pressure, or squeezing. Okay, discomfort. Number two, women have more associated symptoms than men. A man will generally all of a sudden clutch the center of his chest, say, oh, I have a knife-like pain and it's going down my left arm. And someone is on the phone to 911 within 30 seconds. Now let's go back to Sophie. She wasn't feeling well. She had a discomfort in her chest, but she was also shortness of breath, sweaty, nauseated, didn't feel well. Men will less often have those kind of symptoms, whereas in women, they're very common. And you'll note that even though Sophie told everybody on Friday she wasn't feeling well, nobody once, anybody she told said, I think you should go and get checked out. I'm going to call 911. You could be having a heart attack. So someone in her family might have been able to save her if they'd had that information. So symptoms can be a little different, as I said. Number two, we are natural, as women, we are natural triagers. We do it in our lives all the time. I don't know about you, but I can explain any symptom away anytime, and I'm an expert at it. Because we do it for our families, we do it for ourselves, we do it for our colleagues, we do it for our children, we do it for everybody. We're natural caregivers. But in this particular situation, it works against us, because 100% you cannot decide at home if you're having a heart attack. I don't care how good a triager you are. And the reason for that is for us to decide, healthcare workers in the emergency room, that you're having a heart attack, we need three things. We need to hear the description of your symptoms, we need a cardiogram, and we need a blood test. Clearly, you can't do that at home. So you have to come in. There's no choice, because you cannot 100% decide at home. My neighbor, she's 71 years old. I hadn't seen her for a couple of days last year. And finally, after a week or so, I saw her out having a walk and whatever. And it turned out that she had a heart attack, but she stayed at home for 3 days. She wasn't feeling well, discomfort in her chest, feeling a little sweaty, a little nauseated, just feeling unwell, fatigued, but she thought it would go away. She thought it was the flu, something that she ate. She was getting over a cold, et cetera, et cetera. And she did some severe heart damage because she didn't come in time. If she had come in right away, we would have been able to intervene and opened up those blocked arteries much earlier, rather than waiting for the 3 days. So I think that one of the reasons that women are undertreated and underdiagnosed is we're not coming in the way that we should. Number three, 85% of chest pain that comes through the emergency door will turn out not to be cardiac. So what that means is if you come in and it turns out that it's not a heart attack, it'll be something else. It doesn't mean it's not there. It just means it's not a heart attack. It can be reflux, it can be musculoskeletal, costochondritis, it can be a number of things. But if you're told that you're not having a heart attack and you get sent home, don't be embarrassed. Okay, that's a good day. Okay, that's good news. Okay, and you had to come in. There was no way you could decide at home. But if you're one of the 15% who are having a heart attack, it could be the luckiest day of your life. because we can intervene. Whereas if you hadn't come in, like my neighbor, and also, yeah, she sustained damage to her heart, but she also could have died unnecessarily. Number 4, many women will tell me, I give many talks a year about, over the years about women in heart disease and coming to the emergency room, is we've all heard about the state of our emergency rooms. And more, I don't know how often I've heard, I'm not going to go and sit in the emergency room for 12 hours in the waiting room. That's where self-advocacy comes in, because if you're coming in, everybody is triaged, and it's up to us to make sure that nurse who triages us knows why we're here. So for instance, come in and they'll say, why are you here today? I'm not feeling well. I've got a discomfort in my chest. I'm short of breath. I'm nauseated. I'm afraid I might be having a heart attack. You've put it on the table. All you've done is told them why you're here. You're going to help the nurse do their job to get you where you need to go in a timely manner. You will have a cardiogram generally within 20 minutes to half an hour. The blood tests, you might have to wait for the results, but you will not get sent to the back of the waiting room for 10, 12, or 14 hours. So it's a matter of self-advocating and just making our purpose, the reasons that they're clear, so that we can keep you moving and getting the care that you need in a timely manner. So I think all these things are important things that as women we need to know. As I said earlier, chances are you have some of this information, but not all this information given to you. But if we don't know that we should be asking questions about our cholesterol, is my sugar normal? Is my blood pressure normal? Okay. When it comes to physical activity, we know if we're doing enough physical activity, we know if we're smoking, we know how much we're drinking, we know our weight. So there are a lot of things we already have under our control, but I don't think it's enough. I think there's a gap in our care. I think we can't fix it all, but certainly being more aware that we are at risk of heart disease, what it involves, what we should know, and what we can do about it from a self-care point of view. I think we can really change that trend of us being underaware, underdiagnosed, and undertreated. One thing before I open up to questions, I just want to mention, when it comes to undertreated, when it comes to diabetes, blood pressure, and lowering cholesterol, women are less often treated to goal for the guidelines than men are. I think some of the problem might be, as women, we're not all that keen on medications in general. And I know a lot of women will do almost anything not to take a medication. And I truly believe that we should only take necessary medications. And from a lifestyle point of view, as I've explained, we can have a huge impact on our cardiac health. But I think when we look at medications, when we have been recommended a medication, we often think of what might happen if we do take the medication, but we don't often enough flip the coin and look at the other side and say, but what is happening while I'm not taking the medication? Because from a cholesterol point of view, for instance, it doesn't mean that it stays the status quo. The disease continues on while we're not treating it. High blood pressure is the same kind of thing. Blood pressure, the reason we care about blood pressure and heart disease risk is, of course, if it's high enough, is stroke, the risk of stroke, and also heart failure. Your heart's a muscle. And if that heart is beating against an elevated pressure over a long period of time, that muscle can weaken. And we don't want that to happen. We want to prevent that from happening. So I think I'll stop there. I'm hoping I have some questions. And so I think we'll open up to questions now.
Thank you very much, Wendy. That was very powerful and informative. We're so grateful for this time with you. So if anyone has any questions, please go ahead and unmute yourself and ask your question. Wendy, maybe I could start with one. Your program is incredible. As you spoke of, the target age for clients of yours would be pretty much what our age group is at 100 Women Who Care. How would someone gain access to your program?
We're very limited in our resources. As I explained, funding has always been an issue. And in Canada, we spend only 5% of our healthcare budget on prevention. We are actually only 3 half-day clinics a week. So we really, for those women who, for instance, have a family history or have been diagnosed with elevated cholesterol, high blood pressure, etc., they can get an appointment in our clinic, the WHHI, through the appointment center here at the MUHC. You don't require a referral. And we did that in particular because a lot of women don't have GPs and therefore are not able to get a referral. So it creates another barrier. But overall, from a prevention point of view, we really urge women to practice self-care because accessibility right across the healthcare system is limited. And so I can send on, we have a website, also the Canadian Women's Heart Health Alliance based in Ottawa. They have a lot of information about self-care for women in heart disease, as well as the Heart and Stroke Foundation.
Thank you.
No other questions? Come on, somebody has a question or an experience or something to share.
Hi, it's Joanne.
Hi, Joanne.
I'm wondering if we have a friend who passed away after having chemotherapy. She had a massive heart attack and passed away. Wondering if there's a link between chemotherapy and heart risk.
Actually, there is in recent years is a whole field that has opened up, oncology, cardiology, from a radiation plus from a chemotherapy point of view. So yes, there can be a link, and those women are generally followed from a oncology point of view. Atherosclerosis that we've been talking about is a little bit different. In that it's not a result of an assault on our bodies, such as chemo and radiation. So it's a little bit different.
Okay, thank you.
Thank you for the question.
Wendy, it's Aline.
Hi.
Thank you so much for doing this for us. This is wonderful.
My pleasure. Thank you for listening.
You might have mentioned it. I had to pick up a call briefly when you were talking about symptoms, but how does one differentiate between muscular pain from working out, especially upper body, versus chest pain?
Okay, so there are a couple of things. When it comes to angina, angina is a discomfort that comes from the heart. In general, we will start experiencing it on exertion. So if someone comes in and says, look, I'm having this pressure that I get when I'm doing the elliptical or doing my run or my swim type of thing, and if I stop, it goes away, okay, that's a red flag. And the reason that angina generally first shows up on exertion, when we're exerting ourselves, vacuuming, running up and downstairs, carrying groceries, running from here to there, or exercising, is that when we're exerting ourselves, there's more oxygen demand. Our muscles are looking for oxygen. And if there's a narrowing of the coronary arteries, it's the blood that's carrying the oxygen to the heart. Not enough is getting there because there's a decreased supply. Now, if someone's having a heart attack, that discomfort will not go away, okay? Angina will generally only last until you stop the activity, or the average would be 5 to 10 minutes, okay? Whereas if someone's having a heart attack, it will not go away. Now, if someone says, I'm having some chest discomfort, but if I touch it here, it's sensitive, then that will not be angina because we can't reproduce it like that, okay? As I said, it would generally be associated with exertional activity. And also we have to put it in context. If you started a new workout and you were with a trainer yesterday and he was making you do all kinds of, using all kinds of muscles you don't normally, okay, then we can account for it. Right? It kind of makes sense and say, well, I have this sore, my left arm is bothering me, but I started doing new exercises yesterday. So sometimes we can figure it out. But again, if you can't figure it out and if it continues to happen, or the discomfort doesn't go away, you should always go in and get checked out.
Okay.
Not to self-triage too much.
No, but as you said, sometimes with upper body workouts, there could
Very
be
possible.
discomfort. But what I'm understanding also is that when the discomfort comes when we're in au repos, so we're just at rest,
Yeah.
less of a sign.
Yes, it would be less likely. It's only if it's quite progressed that you would get it at rest. Two things we haven't talked about. Number one, stress. Certainly we can get, we might as well be doing a workout. Okay. We live in a stressful world and we don't talk enough about stress. But I know sometimes we can get so worked up that we might as well be doing a workout. And so the woman will say, well, I'm sitting there, but I just had a fight with my husband or my daughter or, a teenage issue or whatever. And that person, as I said, that woman can get so worked up, she might as well be doing a workout. Okay. So there's no hard, fast rules. But in general, as I said, if it is angina, it will generally start off when you're exerting yourself.
Thank you.
This is Dominique.
Hi, Dominic.
Hi. I have a question based on the first person who asked a question about the link between chemotherapy and heart attack. My mother is about to get radiation. And she's 90 years old. She has high blood pressure. She has very low heartbeat, like 35 to 40. Yeah. And she's being monitored by
no pacemaker? Okay.
She goes to see a cardiologist every year and he says, how are you feeling? Have you fainted? Or you feel, no, I'm fine. And so every year he says, you're going to get a pacemaker at one point, but only if your heart goes under 30, below 30. So anyways, so she's going in for her appointment for radiation and they gave her 3 options: once a day for 5 days, once every 2 days for 2 weeks or something like that. And then once a week for 5 weeks.
Right.
Would there be one of the options that would be worse for her heart? Like they didn't discuss that. They just asked her what she preferred.
Okay. That's beyond my scope of practice and I don't deal in that. So I'm going to stay in my field. But that's a good question for you to ask them. They should be, how is someone supposed to decide that if they don't know the pros and the cons? So it's a matter of going back and say, because I've often done it myself and asked that healthcare practitioner, ask questions like that. And what do you think? Because they have the expertise, right? And so because it's not shopping, right? This is serious. And how are you possibly expected to know that? So I understand the idea of options, but you have to have the information to be able to make that choice. And I don't think by the sounds of it, they've given you the information you need.
Well, not much. The risk factors were only, pain at the site, kind of redness and, itchiness, and that's it. So
yeah, I would turn that around and ask them what they recommend.
Okay.
In your mother's context.
Right.
Because they have the expertise.
Right.
Yeah.
Okay. Just wondering.
Yeah, no, sure. It's a good question. Well, because we always land up in these situations. And, in recent years, the whole idea is giving choice. That's fine. It's fine to give people choice, but you have to give them information to be able to make that choice. And we depend on their expertise. We might not want to use their expertise 100%. That's our choice. But we would like to know as professionals what they would recommend or what they think.
Yeah.
Right? So I think we're often intimidated or we don't have time because, you know, they're always kind of rushing through and whatever. But really, you know, sometimes we just have to, you know, push back a little bit and say, just a minute, I need to ask you something or whatever. And that's okay. That's okay. Yeah.
Okay, thank you.
Pleasure.
Hi,
Hi.
can you hear me? It's
Yeah.
Jane. I have heard that numbness or tingling down the arm is one sign of a heart attack in women. Is that true?
It can be. It can be. It's like we're all individuals, so the symptoms can vary. That is possible. There are lots of other explanations. It has to be taken into context of other symptoms that that woman is experiencing at the same time, as well as her risk factors. Okay, but it's possible. And some women have jaw pain between their shoulder blades in the back, can be angina. There's no set thing. So that's why it's important that we report these discomforts. Now, but you know, sometimes you know, between your shoulder blades, it can be your sitting position, you're at the computer, you know, exercising or whatever. So you can never kind of take a single symptom. It's the overall picture. Okay, what's that associated with? It can also tingling and whatever, can be neurological. It can be a nerve, right? So you have to kind of take it into context. I think the message is not to ignore some of these things, because, as I said, as natural triagers and natural caregivers, you know, we're almost too good at it, and we don't tend to report things. And I think that's part of the problem about why we are underdiagnosed and undertreated, is we're not reporting these things because, you know, we don't think they're necessarily important. So I think it's important that we do that. Thanks for the question.
So if you were to start feeling that pressure, that heaviness or tightness in your chest, would you wait a little bit, wait 20 minutes, half an hour to sort of see if it goes away on its own, or is that precious time that you should be getting yourself to the hospital?
I think again, you know, we have a little voice in the back of our head, you know, and sometimes that voice is saying, "Oh, there's something wrong." And actually, there was some of the research that I've read about women and heart disease, and they have kind of this foreboding feeling like there's something wrong, right? And we all tend to ignore these, but in that context, if you know you've got this pressure, you haven't had it before, and you just feel, oh, there's just something not right, and you might have the shortness of breath, the sweatiness, feeling nauseated or whatever, you know, if you wait 5 or 10 minutes, it's not going to make that much difference. But if it doesn't go away, I think the message is, do call 911 or go to the emergency room. Okay, because who knows, right? One of the most recent reviews on globally on women and heart disease is since before 2017 we were seeing a decrease in cardiac events in women, but in North America, the United States and Canada, since 2017 we've seen an uptick, which is really concerning. How can that possibly be? Because we know so much about prevention. We have countries, and so a lot is available to us that is not available other places in the globe. And so I think it's something that it should be on our radar. I don't think heart disease is on our radar. Certainly breast and ovarian cancer are, but considering 1 in 3 of us is gonna, you know, have a heart attack or stroke, I don't think it has the place in our lives or in our consciousness. I don't think it gets the attention it needs. And certainly if we're seeing an uptick, it's very concerning because as I said, it's 80% preventable. And so if it's not on our radar, we're not asking questions and we're not practicing self-care and investigating coming in when we are having these symptoms, we're putting ourselves unnecessarily at risk.
Thank you.
Sorry, it's Catherine. It took me a while to unmute myself.
Oh,
Hi, Wendy.
hi, Catherine.
In terms of the symptoms that are non-modifiable,
Risk factors. Yep.
the risk factors, sorry.
Yeah.
are they, I mean, are all the risk factors sort of weighted equally, or do they have a weighting in terms
Okay.
of, you know, how much you're at risk if
Yeah. Yeah, that's an interesting question. There are risk scales and scores out there. We don't tend to use them because they're not particularly good for women, because they don't take things like menopause, etc., into consideration. So when it comes to weighting things, age probably carries the greatest weight. In that, as I said, with for instance, the Framingham risk score, we gained 6 points from the day before our birthday to the day after. And aging is a natural process, but we can age in different ways. We can age in a healthy way and age in an unhealthy way. So we focus more from the number of risk factors. So the more risk factors you have, the higher the risk you are. So if you can decrease those risk factors from, let's say, 4 to 2 to 1, then you've decreased your cardiovascular risk. But aging definitely has the most when it comes to a weighing risk point of view. And diabetes and smoking have to come second, because diabetes is so dangerous in women. But certainly, if you count up how many risk factors you have, if you work overtime, you know, this is a process. If you work overtime to decrease your risk factors from, let's say, 3 to 1 or even none, get them back to baseline, you've automatically decreased your heart disease risk.
Okay. Okay. Well, that's helpful. Thank you.
Wendy, hi, it's Julie. I don't have a question, but I have to hop off. I have a 1 o'clock meeting. I just wanted to say thank you so much. Very informative. Appreciate all this valuable information. And I'm going to be trying to get into your service, but we'll see.
Well, thank you. Thank you.
Thanks so
So
much.
I guess I'll sign off. I can forward the links for the Canadian Women's Heart Health Alliance, the WHHI online, and of course there's the Heart and Stroke Foundation for more information. And I urge everybody who is on today to share the information you've learned today. As women, we share a great support network. We share information with each other. And so we can easily triple or quadruple the number of women we get this information out to by speaking with our colleagues, our daughters, our nieces, our moms, our sisters, our cousins, et cetera, et cetera. And if you're in a public situation and you see a woman who is not feeling well and has some of these symptoms, you know, don't hesitate to call 911 for her. Because Sophie, the 44-year-old, if someone had called 911 and sent her to the hospital, she might be here today. And, you know, she has 2 children who lost their mom. So I think there's a lot of things that we can do for ourselves and for women in general. So again, thank you very much for giving me this opportunity to speak with you today.